Welcome to another episode of the Workplace Therapy Podcast, where we talk about the realities of working together and healing together. My name is Scott Arrieta. I'm the CEO and founder of Unity & Company. We're the trusted partners that market-leading brands rely on to unify their leadership teams and catalyze cultural transformation. Today, it is my pleasure to introduce you all to our very special guest, Dr. Barzel. Dr. Barzel is an accomplished certified ProSci change management practitioner and learning strategist with over 18 years of hands-on experience driving organizational transformations and delivering strategic change consulting, and recognized as an expert in high-reliability organizations. Dr. Barzel has a proven track record in large-scale systems training, leadership development, competency modeling, and strategic planning process across diverse sectors, including healthcare, civil, and defense government clients. As a faculty member at Vanderbilt University in Nashville, Dr. Barzel teaches courses in organizational change management and strategic human resources management, shaping the next generation of leaders as part of Peabody's Leadership and Organizational Effectiveness track. With advanced degrees including a Doctor of Education in Leadership and Learning in Organizations and a Master of Education in Curriculum and Instructional Leadership from Vanderbilt University's Peabody College, along with a solid foundation in education and history, Dr. Barzel brings a rich blend of academic rigor, practical expertise, and passion for empowering organizations to achieve sustainable and high-performing cultures. Dr. Barzel, we are so grateful to have you on the show here.
Well, thank you. Thank you for having me. I appreciate it. I'm looking forward to our conversation.
Me too. Now, I'd love to just start by acknowledging that your career has given you the opportunity to engage in some really interesting and meaningful work. Can you tell us a little bit more about how you found yourself on this path?
So you're right. Management consulting is something that I spent most of my life doing. And I had the opportunity to explore a lot of different problem sets with a lot of different clients. And in doing so, it's really been a blessing because I feel like I've worked at many different places and I've had exposure to just so much that I would not have seen in any other context. But there was one thing that I had the opportunity to participate and support, which was VHA's journey to high reliability. And that stemmed from this real interest in patient safety. And I was just moved by VA's really bold take on how they approached patient safety. They did it in a dynamic way, something I'd never heard of anywhere before. And the more I learned about it, the more I got into it, the more I read about it. Thankfully, I had an opportunity to support them for many years in going around to hospitals and hospital systems across the United States, coaching and observing and taking note of what tools are in place to advance patient safety using kind of this change management and learning and development lens. And then what opportunities are still around to fill in some of the gaps that are missing.
I'd love to explore that a little bit more in depth. You know, when we first met, you had told me a really fascinating story about a case study regarding a nurse by the name of Redonda Vaught. Would you mind recounting that for us so that we can explore that in a little bit more detail?
Yeah, it's a fantastic story. It's tragic. I don't mean fantastic in that it's a good outcome. It's a bad outcome. It's a tragic outcome. But it takes place in Nashville at Vanderbilt University. I'm in Nashville. And it gained national attention at one point. First of all, let's start with a patient by the name of Charlene Murphy. It was Christmas Eve 2017, and she had a subdural hematoma. That she was at Sumner Regional Medical Center, and she was transferred to Vanderbilt. And part of her care was to get what was called a PET scan or PET scan. And Miss Murphy, I think at the time was 75 years old or in her mid-70s, an elderly patient, was just claustrophobic and very on edge about going into this machine to get this brain scan. Redonda Vaught at the time, this nurse that you mentioned, had been practicing for a few years, had great rapport with the staff, had great reviews by her clinical team, and there were no red flags. But she was working as a float nurse. And as a float nurse, you could imagine it's really challenging because if you are a peds nurse, for example, and you suddenly have to fill in and work in cardiology, you're like a fish out of water. Sure, you're a nurse, you have certifications, you're trained, but you don't know the meds that go on in cardiology. You're not familiar with maybe the procedures or the behaviors of the patients are different. The problem sets are different. Anyway, so she's a float nurse in this case, and she's actually being shadowed by a nursing student. So, the center, Vanderbilt has given her, obviously you're not going to shadow somebody who you don't have confidence in or put that person in a position to be shadowed. So she's being shadowed, and Charlene Murphy is not her patient because she's a float nurse, but the nurse that's assigned to Charlene Murphy. They go down, they try and get the PET scan, and she's freaking out by the claustrophobia. So the doctor says, okay, you know what? Let's order some anti-anxiety medication. It's very common in a hospital called Versed. Versed. And so they call up Redonda and say, Redonda, hey, can you come down and administer this intravenous sedative to Miss Murphy? She goes into the medication dispensing cabinet, and there's a computer system and a medication cabinet below at Vanderbilt, and she's quickly trying to look up Versed in the patient file and isn't finding it. So she starts looking up VE, the first two letters of Versed, VE. And sure enough, another medication, a medication pops up, which is called vecuronium. And unbeknownst to her, a series of maybe just cognitive slips or whatnot, or the chaos of just dealing in clinical care, she ends up selecting vecuronium. Now, vecuronium is probably the most dangerous drug in a hospital. It's a paralytic drug used in anesthesiology. I believe it's used when you intubate a patient. It's extraordinarily dangerous and it needs to be monitored with the right doses and everything. Well, she administers this medication. The system does give her this override, are you sure you want to dispense this medication? She bypasses the override system. The dispensing drawer opens and she administers it to Miss Murphy. And within less than 45 minutes, unfortunately, Miss Murphy dies.
Wow.
And the error went unnoticed. Initially, Redonda Vaught, being a float nurse, went on to another task and didn't sit by the patient after the medication was administered. So there's some missteps going on here. And then another nurse walking by notices that Charlene Murphy is not responsive. Something's not right. And they check on her and they do a code because she's not breathing, and they try and resuscitate her, and to no avail. And what makes the story more fascinating is that Vanderbilt, so when people had kind of started to uncover, wait, what happened? Who was there? And they went to Redonda and said, Redonda, what did you give her? And she had, or they after a medication is used, from what I understand, it's put in a special bag and it can either be repurposed or it's meant to be eliminated or taken care of, properly. And they have the bag. She had the bag. They pull it up and they look and they say, oh my, you did not give Charlene Murphy Versed. You gave her vecuronium. And she was just, from all accounts that I've heard, I've never spoken with Redonda Vaught, but from all accounts, she was mortified and took immediate responsibility and blame and was cooperative and was just beside herself. Oh my goodness, how could I have done this? What just happened? Obviously, this turned into the worst day of her professional career, and and for Charlene Murphy's family, this tragic outcome. Redonda went back and she talked to all the clinical team about what happened and she took full accountability. And then when it was time to produce a death certificate and to explain what happened to Charlene Murphy's family, Vanderbilt made no mention of a medication error. They said she died from her subdural hematoma. So you have a story that in the headlines sounded very salacious because it was, Vanderbilt nurse kills a patient. And on the face of it, if I were to ask you what should happen in clinical care when somebody is responsible for the death of a patient, whether it's you, Scott, or someone else, people have very strong reactions. If I said to you, do you want her to be your nurse? Probably not, right? Do you want her to be a nurse again? I don't know. You might say probably not. Should she go to jail? Maybe. A lot of things happen in the interim that I'm leaving out. But essentially, the district attorney opted to charge Redonda Vaught with reckless homicide. And it immediately, I told you, it gained national attention. And it wasn't so much national attention because of the death of a patient, which is tragic. But it gained national attention because Redonda Vaught made a mistake. And there were a series of mistakes that were made. And it's easy to put blame on Redonda. But because Redonda Vaught made a mistake, it went from this very understood paradigm of to err is human to this concept of to err is criminal. And nurses around the country rallied behind Redonda Vaught, saying, I've made medication errors too, or I've made other sorts of errors. Let me give you a quick example. If a nurse gives a medication error, you and I may have had many times where someone gave us maybe Tylenol if you're in a hospital or Advil, and they gave us the wrong dosage. And maybe they gave us, 2 pills instead of 1, or they gave us Advil instead of Tylenol or whatnot. And you might say to yourself, okay, well, I had no adverse effects. probably didn't know about it, and we move on. But the idea here is that in healthcare, mistakes are going to happen. I read a study out of Yale. It was published in 2020. Approximately 22,000 people die every year in the United States due to medical error. Preventable harm. Many, many, many thousands or more don't die. Medication error is often actually one of the most critical. We either give somebody the right medication, but we give them the wrong dose. Okay, so they got the right medication, they got the wrong dose. Or we gave them the right medication, the right dose, but we give it to the wrong patient. Someone with a similar sounding name, or there was confusion, or a nurse is about to administer medication and there are two patients in the room, and something happens where the nurse is distracted and something happens outside of the room that is maybe more pressing. Maybe somebody fell. They go outside, they investigate, they take care, they come back into the room, and they remind themselves, okay, wait, yeah, I followed the steps. I scanned the barcode. I scanned the patient. All right, I just have to, that's all I was left was giving the medication. And they give it, but they give it to the wrong person. And you might say to yourself, how could this happen? When you think about the Redonda Vaught case, it's a great springboard into what I've been working on for years, which is high reliability in organizations. And high reliability in organizations is, unless you work in these high risk organizations, and it's not a concept that's often talked about, but it's a fascinating approach to how we reduce error. So look, even in the Redonda Vaught case, we think about this and we think, how could she have picked the wrong medication? How could she have given it to her patient? How could she have not stayed by the bedside? All of these things that it's really easy for us in our society, which is quite a litigious society, that we're very used to pointing blame. And so we say to ourselves, okay, well, look, if I get rid of her, I've solved the problem. But it's not complete. It's not a complete picture. I start to tell you that why are we storing the most dangerous drug in a hospital in every medication cart? Why is when she went down to radiology to administer this medication, Versed, there's no barcode scanner in radiology. She wasn't in her room. Why can somebody type in two letters of a medication's name and it not auto-populate? And why is it auto-populating? Like, what, don't we have safety guards, like safe kind of guardrails that would prevent this from happening? And, Versed wasn't found, by the way, because it was under its generic name, not its brand name. So some names were under generic names, some names were under brand names. Imagine how confusing this system is. And then, Scott, we also think about like nursing in general or clinical care. It's still quite common for clinicians or nurses especially to operate on these like 12-hour shifts, multiple days in a row, right? You might have like a 12-hour shift and then maybe 2 or 3 or 4 days off, right? You can see her on her second hour or his second hour of their shift or their 35th hour of their shift after 3 days. Like, we kind of have to review and take a step back and say, okay, it's easy for us to blame the person, but there's often a system error that's happening. It's systematic of something larger. Why are we doing this?
This story, Dr. Barzel, really resonates with me and is challenging to think about because I think there are multiple layers of implications here. The first that I want to kind of call out and spotlight that I think is fascinating is how accustomed we are, particularly in American society, but Western society in general, towards blame. And I think it's interesting that you correlate that to our litigiousness. I don't know which is causal. I don't know if it's like we have a tendency to blame and it manifests in our litigiousness and then it perpetuates organizationally because we're afraid of litigiousness, or if it's just that we fundamentally seek to blame as a way of trying to provide context and make us feel safe and secure by assigning the blame to some external force. And then to your point, getting rid of that external force. And we say, okay, like we are now completely safe again. But to your point, the actual danger lies several layers underneath. And so I think that's a really interesting thing to explore. Maybe we can dive a little bit deeper there because the audience will probably be split. People who would say the right thing happened here to Redonda. It was right for her to lose her job. Ultimately, a patient died under her care and it was due to some form of negligence. And then there will be other people who might say, listen, it's unrealistic to expect that in a high stress environment like that somebody could operate flawlessly without necessary safeguards in place. And so the question then is, how could we have better supported Redonda and nurses in that situation to not make a fatal error in the future? And what responsibility does the person or persons who designed that system actually have in the outcome here? I don't know that that was discussed or even investigated. Do you know in this case?
I don't know in this case. I don't know enough about it. And I know that, Vanderbilt settled with the family of Charlene Murphy and tried to kind of brush it under the rug. But, when you look at a system, when you think about accountability, you can't hold Vanderbilt accountable. It's not, it's a medical center. It's an entity. It's not a person. So, but when you can point at a person, you have a scapegoat. You can say, okay, look, we took care of it. We identified the source of the problem, and we did the right thing by eliminating it. You talked about this obsession being in a litigious society, but one thing that I tell my students when I talk about this case with my class, I often ask them, hey, just take a moment, see if you can find your car insurance card. And I don't, and I used to have mine in my wallet. Now it's like on my phone, right? But it'll say, number one on the back of the card, call 911 if there's been some serious injury involved. And inevitably, number two says, don't admit fault. Like, this is it. We are accustomed to not accepting blame. And I was talking to my wife about this because she's an attorney at a large healthcare provider. And just from her perspective, I was thinking, isn't it crazy? Like, what should we advise people? Like, if they made a mistake, do you think it's best to own up to the mistake and tell the family, hey, I messed up? Or is it best to let the legal system no, have this deniable plausibility, no, I'm not sure it was my mistake. It could have been someone else's mistake. It could have been this, it could have been that, and let the system kind of play out, right? And she reminded me that there was plenty of evidence that more often than not, when you admit fault, when you take responsibility, people are far less interested in legal action. They just want someone to say, I'm sorry, I messed up. This is my burden too. It's on me. Once I think Vanderbilt started manipulating the death certificate and started kind of hiding everything, and this didn't come to light for another while, like a year after this happened or 8 months after this happened. Like Charlene Murphy's family did not know about any of this. That's when you start to get this well, no, now I want Vanderbilt to suffer in some way for not coming clean and not just sitting with me and explaining, this is what happened. It was chaotic. This is what we're going to do about it. This is what we've learned from it. And so I was telling you that I got really fascinated with this idea of high reliability organizations. And high reliability organizations is often not a common, it doesn't roll off the tongue so well. I'm not sure what it is necessarily. They're essentially organizations that operate in a high risk environment, but yet maintain low error rates. And they have to do it by following some sort of plan or procedure or approach. So if you think about let's kind of brainstorm examples of industries that operate with high risk. So I'll give you, healthcare is one. Any other industry can you think of?
Military?
Great. Excellent. Military is another, right? A lot of risk. If it doesn't go well, it can be detrimental. We talk about aviation. Aviation is a big one. In fact, aviation was the predecessor to HRO. It was called crew resource management, and it's still used in aviation. There were so many air disasters in the 90s, and now we have a spate of them coming back, right? It's like what happened over the Potomac with a helicopter and a passenger jet, and the flight that ended up upside down, I think, in an airport in Toronto. We're starting to kind of uncover more and more accidents and near misses in aviation. But the idea in crew resource management was, let's just stop and standardize some of these things that we're doing, because there was no standardization in aviation. You being the Delta and I being American Airlines could have different checklists, which is crazy. We could have different protocols on how we do things and handle things. If there's an emergency, you have your way and I have my way. And I mean, it seems crazy until something bad happens, and then you kind of scratch your head and you realize, right, stupid is as stupid does. And so in aviation, they said, okay, well, look, let's just take a step back and understand what are the most dangerous times of a flight's journey. You want to take a guess?
Well, I would guess takeoff and landing.
Okay, excellent. So 2 of the 3 are takeoff and landing. The third is taxiing. A lot of times,
I would have never guessed taxiing.
I know, right? Like clipped wings or whatever, an aircraft runs into another aircraft or whatever. So the crew resource management, under this whole paradigm, said, okay, look, let's institute what we call a sterile cockpit. And a sterile cockpit means that during the 3 most dangerous times of a flight's journey, like you said, takeoff, landing, and then taxiing, you are not allowed to engage in idle chit chat. But when you are flying and you're cruising at 20,000 feet, it's not realistic for you and the crew, the first officer, the pilot on larger aircraft, the navigator. It's not realistic that all you're doing for like a transatlantic flight is talking about the instrument panel. Wow, it's still showing 20,000 feet. Like, oh my goodness, you go crazy. Like the idea is you should engage in conversation and chit chat about your kids and your grandkids and where you like to eat and where you want to go to just keep you awake and aware. But again, during those 3 times, we shut it down and we say, this is a sterile cockpit now. We have to hyper focus because so many errors happen due to distractions. I've seen in hospitals a really interesting approach to this. I was telling you that medication, so we do operate on the wrong leg. We do give people the wrong medication. We do this. Medication dispensing is one of the most common forms of preventable harm. And so a really interesting low-tech idea that I've seen at different VA hospitals, and it's probably taken off beyond them, but I've only worked with VA, and I'm just so impressed with them on this journey, is when a provider or a clinician or someone is dispensing medication, they will put on a safety vest like you'd see construction workers wear, right? Like, and I use it to walk my dog at night, but that's because it's pitch black and I have no sidewalks. This is like bright lights and you're wearing it in the middle of a hospital and you're kind of like, why are you wearing that safety vest? And they call it a visual reminder, a visual indicator that, look, hey, right now I'm doing something really important. Don't bother me. Because it's the distractions that cause us to make errors and make mistakes. And so in these examples of high reliability organizations, we're constantly trying to figure out what can we do to look at from a systems level, not just the person. What systems are in place to prevent harm from happening in the first place? I'll give you this great example and again, unfortunately, these examples, the ones I have are so often tragic. But I was telling you that aviation, you talked about the military being an example, something that operates in extremely high risk environments, yet can maintain low error rates. Another one that people often don't think of are amusement parks. And I'm not I don't want your listeners to be like, oh my gosh, this is this is like when you see like the evening news and like death by escalator. These escalators are so dangerous. It's not that. Like, go to the park and enjoy every minute of it. But amusement parks operate with a lot of risk. And there was this tragic story of an 8th grader. It was in Orlando at Icon Park. So, Orlando being home to Disney and Universal is all, anyone who can kind of come up with another amusement park will do it. And so this small park came out called Icon Park, not affiliated with those 2 big ones. And they boasted a bunch of different rides. And one of them they were most excited about was this ride that was, I think, a free fall from 430 feet. You kind of have to imagine like a massive circle where all the seats are facing outward. You've seen these free fall rides, right? They drop and
Right.
they stop suddenly, and you don't know as a rider when they're going to stop, and then they go up, and then you don't know when they're going to drop again. Well, this thing at its top speed reaches 75 miles an hour. Okay, like when it's dropping. And it's 430 feet. And I think it was the tallest one of these rides, at least in the United States, if not in the world. I can't remember. Nonetheless, this kid, Tyree Sampson, 8th grader, big kid for an 8th grader. He was a football player, aspiring football player, like go professional, and he's 6'2" in 8th grade, and he's 330
Wow.
pounds.
Yeah.
He's a large kid, and he's with his friends, and I think maybe a cousin or something at this park, and he's calling his mom, and he's in tears. He's saying, "Look, no one's going to let me on this ride. These rides, there was like 7 or 8 rides at Icon Park. No one's letting me on these rides. I'm too big." And he was really sad because he felt ashamed, he felt embarrassed, and and just left out. And his mom's consoling him, and I'm so sorry, sweetheart, and like it's unfair, and whatever she would say to her son in a loving and kinding way. And so fine, they hang up, and he calls back like maybe 5 minutes later, and he's like, "Mom, you wouldn't believe it. They let me on this ride." And his friend or his cousin was filming this. And he went on the ride at Icon Park, the one that I was telling you, the free fall. Well, if you can picture the harnesses, right, that come over your shoulder, because of his size and his girth and just his dimensions, the harness does not come and is not like, in an ideal scenario, the harness comes all the way down, and what you're holding on to on the sides is like a 90-degree angle to your legs, but not for him, right? The angle is much wider, and the space in between the harness and the seat is a much bigger gap. And going at 75 miles an hour with a sudden stop, he slid through and he fell to his death.
Oh.
And so, when you look at this story, you kind of think, well, wait a second, this is what, you might just kind of resort to this blame thinking. We do it so often. We say, okay, oh my gosh, what person, what employee, whatever would let this kid onto the ride? Clearly, the other ride operators understood that he was not fit for their rides. What is wrong with this person? Why would they do it? Clearly, they need to be maybe they need to be charged. Maybe they should be charged with reckless homicide for participating in this death. And I say, when we look at all these things, and I understand it, like our go-to is who did it. We just want to be able to point a finger. But if you start to picture, like, you're not talking about a ride operator here with an advanced degree or an engineer. Someone is trying to make a decision. They're probably, like, you're talking about making minimum wage, high school, maybe just after high school, trying to just work. I mean, not someone like, you're not interviewing them in their job interview. Are you qualified to size somewhat up to understand if they can fit in this ride? No. If you go to this ride, there was a chart that only had a height requirement. And if you've ever taken I took my kids to Disney, right? And my kids would like try and stand on their tippy toes because they just were desperate to go on these roller coasters because it was a height thing. It's not a weight thing or a dimension thing. And so he went on the ride. And again, from a blame culture, we eliminate the person, the ride operator. We've solved the problem. It's never going to happen again. That person is gone. They were an idiot. We can blame them. We can say nasty things about them, and we can move on. Well, Scott, the reality is there were a lot of problems here. There wasn't a clear protocol on size dimension, and there wasn't a backup safety feature which would have prevented this entirely thing, which is like a $13 seatbelt. Just connecting the seat to the over-shoulder harness, that would have prevented this entire. So in a blame culture, we're looking at who did it. And what high reliability does is it looks at what's called a just culture. And in a just culture, we're interested in what happened. What happened? What can we learn from what happened? What can we do differently? What went well? What didn't go well? What would we do differently next time? But in order for a just culture to operate, so many things need to be in place. And one of the biggest ones is how we respond to people who make a mistake in those environments. So when you look at what happened to Redonda Vaught, just ask yourself, if you were a clinician at Vanderbilt at the time of Redonda Vaught, okay, and you saw what happened to her, would you ever tell anyone if you made a mistake? And I'm not talking about a lethal mistake. I'm talking about just a mistake.
Because this is what Amy Edmondson talks about when she, in her work on trust and psychological safety. I remember, a study I was reading that they had done comparing error reporting in high trust cultures versus low trust cultures. And the result was counterintuitive at the time, but it was low trust cultures had lower error rates. But really it was lower reported error rates because the low trust was manifesting in people not being willing to admit mistakes. And so to your point, in the Redonda Vaught case, if the level of accountability and introspection ended with the termination of Redonda Vaught, you still have a systemic issue in play, and something that bad could happen again, like into perpetuity, because you haven't addressed the actual root cause. And the only way to actually get there is to ramp up the trust, ramp up the reliability of your systems, right? By like looking at things way more comprehensively. But like I see this mistake in a lot of organizations where they rob themselves of the benefit of actually nipping problems in the bud because of the almost reactionary and reflexive tendency to blame and terminate, and then refuse to kind of even investigate the issue even further.
You're right. Amy Edmondson is a really great. I think she is responsible for kind of bringing this idea of psychological safety to the forefront and understanding that, like, look, if you don't feel safe, you have to have a certain amount of vulnerability in your workplace or the people you spend time with. That if you make a mistake or you say something that maybe is not correct, that you have leeway, that you have some grace. And psychological safety is saying, well, look, if I don't feel safe expressing a concern I have or an error I've made, then the organization doesn't get to learn from them. So in the blame culture scenarios, the other nurses are maybe making other sort of medication mistakes, but they're not going to say anything. Now, this is where it gets fascinating, because if they don't say anything, the organization doesn't have a good sense of where their vulnerabilities are. And there is a organizational psychologist out of England named James Reason. He was studying large disasters and kind of trying to figure out how they happened. 3 Mile Island or nuclear disasters or whatnot, and aviation disasters. How did these events occur? And he started to come to the conclusion that it was more about the system than the people. And he started to liken it to this idea of layers of Swiss cheese. He said, okay, look, we have layers that are there to protect us. So in a hospital setting, a layer could be competency of the individual, right? They're trained, they've gone to accredited program and school, they're up to date on their training, whether they're, a dietitian in a hospital or they're a nurse or they're a surgeon or whatnot. Okay, we have a competency layer. We may have a team layer where like the team is cohesive and working, operating properly. We may have an equipment layer or a technology layer where we say, hey, look, there's a scan process here to protect the patient from getting the wrong medication. Right? We have these layers and they're fantastic. And it reminds me of like, okay, when I go in for a procedure, I'm happy but alarmed at the same time when they say, can you tell us why you're here? And I'm like, oh my goodness, this is not starting off well. If you don't know why, and of course they know why, but one of their questions is to validate that they have the right person. And so you have these layers in place, like you have this technology or system or policies. Maybe you have an outline of policies and procedures that are listed, and they are meant to protect an organization or an individual from harm. But if you think about it like James Reason does in a concept of Swiss cheese, every layer has holes. And those holes he likens to vulnerabilities. And the idea is that maybe you have a layer of policy. So you have a layer to protect you, that we have guidelines and policies, and this is how things should be done. Eventually, policies and guidelines get outdated. And if they're not constantly updated or thought about or communicated by the new updated policy, then that becomes a vulnerability. So something that's there to support you is also something that can harm you, right? If your technology is faulty, or like we just saw, yes, there's a medication dispensing unit. Yes, you have to type in the medication, but when you can only type in the first 2 letters and it auto-populates like we do when we text, that's a vulnerability. It's a vulnerability when you have half medications being searched by generic names and half by brand names. That's a vulnerability. So the idea here is, if nobody has psychological safety, if nobody's willing to tell their supervisor and the supervisor is willing to tell the manager and the manager is not willing to tell, if it never makes its way up, then nobody understands where the holes are and what we need to fix. Medications are often stored together that are very similar looking. And, it could be that you're used to seeing, if you're an anesthesiologist, you're used to seeing this little brown vial with an orange cap, and it's the medication you always administer. But you know what? We had a manufacturer change, and the hospital didn't communicate it because they found like manufacturer that's going to do it for cheaper. And now it's the brown vial with a green cap. And you still pick up the orange cap, but it's a different medication that happens to be stored there because someone made a mistake, because they too weren't expecting that I'm just saying, it's over the instances of care, over millions of iterations of care. Eventually, harm is going to make its way through. And on a given day, harm will pass through a first layer, but be stopped by the second layer. And the second layer will prevent the harm. But when all the bad karma aligns and it just happens to be like a 3 Mile Island or an aviation disaster, we give someone the wrong medicine and we kill them, like all the holes aligned. What are the layers we can put in place? What are the layers to protect people, and how do we find them? And you're right. Amy Edmondson talks about psychological safety being as this one way that we can identify, like, I don't know if it's TSA or whoever, did a great job initially, especially after 9/11, of like, if you see something, say something. And I thought this was a really interesting approach. Like, I thought conceptually, this was a really great way to deputize all of us to participate in like safe flying. Because if you think about it, if you've got at a given airport, uniformed officers and 20 plainclothes officers, and you've got thousands of passengers and thousands of moving parts in different places, well, why don't I just give everyone the opportunity to be vocal? And I love it. I really think it's very powerful. But then when I ask you, if I ask anybody, and I've asked my students this all the time, like, how often do you say something when you see something? Because it feels like, oh, of course I would. Of course I would. So then I give them the very simple example. Okay, great. You now are at your favorite lunch place that's fast food. You're at a Chipotle or a Subway, or I don't care, wherever you eat, fine. And you see the person making the food wearing gloves. And you see them handling the cash register, and then they check their phone, and then they go back to making your meal. It's gross, right? Like, it's gross. It's totally like yuck. And it defeats the purpose of the gloves, right? You're like, why are you wearing gloves? You've done everything. You've touched your face. I've seen you scratch at a scab. I've seen you handle the cash. I've seen you take my card. I've seen you take your phone out. And then now you're making my sandwich. Lovely. I'm so excited. How many people say to the person making their food, hey, can you please stop and change your gloves? It takes a lot. And I'm talking about, this is like rather inconsequential. Like, okay, yeah, you might get a stomach ache. Or you might just be gross, or you might be gross. I'd not want to eat there again. Right. But, if you see something, say something is brilliant, unless you feel comfortable saying something, unless you feel empowered to say something, then you just won't. And now imagine yourself. Now go back to this hospital setting. You asked me at the beginning, like, what got me into this? What got me passionate about this? And it's this kind of like change thinking. It's this kind of systems thinking. I'm at a point where I'm thinking, okay, look, imagine a nurse in a room with a surgeon. And a surgeon comes in and is about to change the gauze on a dressing and a wound on the patient. Okay, so surgery was a few days before, and the surgeon's coming back to do a check to make sure everything looks great. And you notice that when the surgeon came in wearing gloves, you as the nurse, okay, you and I are the nurses in the situation, you notice that they didn't do what's called proper hand hygiene. They didn't replace their gloves. Now, I'm not saying they're a bad person. They're not. They have what we call in high reliability a cognitive slip. Okay, just human error. They are proficient at their jobs. They're good. They're not trying to spread harm. But the reality is that sepsis, as being a hospital-borne infection, is like really scary in a hospital. It leads to people having amputations. It leads to death. It's terrible. And so you are now watching this doctor come in, the surgeon come in, and everyone's happy, and it's a hello, and they exchange pleasantries, and they're about to now change the dressing on the wound. Did you say something? No, I don't know. I hope we would all want to say something. But the reality is, if you're thinking about a situation where there's hierarchy, you know how hard that is?
Yeah.
If you can't even tell your sandwich maker to change their gloves, are you, being a nurse watching your surgeon come in, going to say, hey, doctor, you didn't change your gloves? Like that takes a lot. And so what high reliability does is institutes a lot of safeties in place. So it's not just psychological safety. AHA, for example, instituted this training. But the idea is, like, let's think about how we operate as a team in this environment. And one of the things they do is they, on purpose, move people's titles from the conversation. So if you're the surgeon and I'm the nurse, enough calling you doctor. Because all I'm doing every time I call you doctor is I'm creating a relationship differential here. And instead, we're all on the same page. We're on the same team. We're here to provide clinical care to the patient. We're all in it together. So what I need to do is just say, Scott, hey, can I talk to you for a quick minute? Put you aside. And then they incorporate, I've seen incorporated, everyone does their own thing, the 3 W's. What I see, what I want, what I'm concerned about, and what I want. So what as I see is you came in the room wearing the same gloves. What I'm concerned about is you're going to potentially cross-contaminate, from wherever you were, the door handle you used to open the door, whatever it is. And what I want for you to do is just take a quick second to change your gloves. Now, and it's a beautiful approach, but it's really hard. It's really hard because we have hierarchy. We have military hierarchy. We have hierarchy in any organization. And you kind of feel like you're second guessing your boss.
Dr. Barzel, I really appreciate you spending the time with us today to give us all of these examples from these high-risk organizations, because I really do think that it helps us to kind of see how the organizations and the environments that we work in are susceptible to exactly the same issues potentially, but also could benefit from leveraging these concepts to make things better and to actually solve the root cause of problems over time. You're obviously a wealth of of information and expertise in this area. If any of our listeners wants to reach out to you and maybe continue the conversation, what's the best way for them to do that?
I would love it. This is something I'm very passionate about, and I spend a lot of time thinking about and writing about. So if you want to know more, you want to get in touch, email is probably the most efficient way to reach me, and it's Barzel. So you see my name there listed. There's no spaces. It's URBARZEL@gmail.com. And that's probably the best way to reach me.
Well, I hope that people do, because we would just be so much better off with someone of your perspective helping us to design process moving forward into the future. I want to thank everybody for tuning in to our enlightening conversation today with Dr. Barzel. If you enjoyed this podcast, please consider subscribing on Apple Podcasts, Spotify, or wherever it is that you get your podcasts. And if you're interested in working with Unity & Company or discovering a little bit more about what we do, just drop us a line at info@unityandcompany.com. Thank you, and we'll catch you all next time.